for probably most people. Let me try to get it to, we're just going to talk about how to obtain a waiver to be a prescriber for buprenorphine, and particularly focus on the recent updates in April of some additional simplified ways to become a waived prescriber. So we'll quickly look at the origins of why we even need a special waiver requirement to prescribe buprenorphine, and then look at those updated practice guidelines from 2021 that were issued from the Biden administration. And then just remind people that besides registering with SAMHSA and getting a waiver to prescribe, there are still additional requirements at the state level and sometimes by payers as well. So just looking at the history of why we even need a waiver to begin with, that really started in 1914 with the passage of the Harrison Narcotics Act. This was a time in our country, late 1800s, early 1900s, where we had a very similar problem to what we've had with opioid use disorder, morphine in particular, but also opium. And the federal government was worried about this. They decided to try to control the supply side of these narcotics and passed this bill. And the Internal Revenue Bureau, which is now the Internal Revenue Service, was the first enforcer of this legislation. It was all about taxation. It wasn't about, it was about limiting or recording the importation and the manufacturing and distribution of narcotics. And a tax was paid on inventory. And then there had to be very specific record keeping of transactions. And that the whole term NARC comes from the narcotic division of the Internal Revenue Bureau. So the physicians at the time could still prescribe narcotics like cocaine and morphine and opium, but it had to be for medical necessity. And the enforcement agency, the narcotics division, defined medical necessity as an exclusion for prescribing it for the purposes of maintaining someone that had substance use disorder or opiate use disorder. There had been clinics set up in the early 1900s to do exactly kind of like what we do today, but with what they had available at the time, morphine. And they would maintain people that had become addicted to opioids on morphine. But the narcotics division and subsequently the Supreme Court of the United States determined that prescribing was not medically necessary and was outside the scope of medical provision. So it became illegal and some physicians were arrested, and that ended the maintenance programs for OUD until 1971. And in 1971, the Comprehensive Drug Abuse Prevention and Controlled Substance Act of 1970 was passed, and under rulemaking, they allowed the investigation of trying methadone, because if you recall from history, we had some issues with Vietnam veterans coming back home with heroin addiction, and was also largely in the inner city. So in the mid 60s, some physicians had done some research with methadone and found it very effective for allowing people with heroin and other opiate use disorders to get back to a functional life. And so the regulations in 71 allowed the investigational use of methadone. And then in 1974, it became effective. Congress recognized methadone as an appropriate treatment for maintenance for patients with opiate use disorder. And the FDA and DEA at the time were combined enforcement agencies of that law. And that's when the predecessor of the current opiate treatment programs came into play. And OTPs have to register, even now, have to register annually. So, and there's a lot more regulation around OTPs. In 2000, we get to the Data Act, and the Controlled Substance Act was amended, and it allowed physicians to prescribe or dispense certain opioids for maintenance without registering as an OTP and all those other regulations that are associated with it. And that's the advent of the waiver. A waiver is basically the waiving of that required annual registration and all the other requirements. It was approved only for non-Schedule II opioids, so Schedule 3 through 5. And That's when physicians started prescribing Suboxone, buprenorphine. In 2016, PAs and nurse practitioners also became eligible to be waived prescribers. That was for a 5-year pilot. And this isn't on this slide, but in 2018, the Support Act was passed, and that made permanent PAs and NPs to be continuing waived prescribers, but also added other categories of advanced practice nurses like clinical nurse specialists and certified nurse midwives and CRNAs. So to apply for a waiver, you do this through SAMHSA. You have to be a qualified practitioner by the code's definition, the United States Code's definition. And those that are qualified include those physicians that are certified in addiction psychiatry or certified in addiction medicine. They automatically are qualified practitioners. If a physician is not one of those, they can take an 8-hour course with requisite topics as defined in the US Code. And if you're an APRN or a PA, if you have in your state the allowance to prescribe Schedule 3 through 5 controlled substances, and you complete 24 hours of a course with the requisite topics, you too can be a waived provider. And these are the topics that must be by statute covered in the either 8 or 24-hour course. The prescribers here have all taken this, well, unless you're addiction or psychiatric certified, but these are the typical topics. The waiver actually is applied for, it's called NOI or Notice of Intent. And again, you do it through SAMHSA. It's a really easy process, frankly. You just have to provide evidence that you're a qualified provider. So if you're not certified physician in those 2 categories, in addiction psychiatry or addiction medicine, then you upload your license and show evidence of your 8-hour course. You have to, if you're a nurse practitioner or PA, you have to show your license and upload your certification for the 24-hour course. You have to attest to your ability to provide or refer patients for counseling or and ancillary services. And then you say how many patients you intend to treat. Historically, before the Support Act was passed, most did 30 the first year, 100 after year 1, and then they could go up to 275 if they want. Now that you can start right out with 100 if certain conditions are met. But if they're not, you can start out with just 30 patients the first year. And then when you do increase from one category to another, as far as number intending to treat, you have to go back into SAMHSA and update your NOI. There's conditions to be able to qualify the first year for 100 patients are, again, be certified as addiction medicine or addiction psychiatry. That automatically qualifies you. Otherwise, if you work in a qualified setting, which generally speaking is pretty easy to meet, particularly if you're working with healthcare systems that most of us do these days, as long as there's after-hour coverage and case management and an EHR, if everybody else in the practice setting is required to use the EHR. If everybody's paper, you don't have to use an EHR. It just has to be consistent with the entirety of the practice setting. You also have to be registered with your state PDMP, and you have to accept third-party payment. Doesn't mean you have to accept, doesn't mean you can't take cash for any patients. It's just that you have to be registered with some third-party payers. So we're going to look quickly now at the approaches that the Trump administration and the Biden administration took towards trying to update the practice guidelines for waiver prescribers. So President Trump, you notice the date, it was a week before he left office. He had his HHS report new guidelines to prescribe buprenorphine. And it basically eliminated the waiver requirement for physicians only, no advanced practice providers, if you were only going to treat up to 30 patients. That's for ambulatory care. If you're a hospital-based physician, there was no limit, and you did not have to engage with SAMHSA at all. You didn't have to file, you didn't have to do anything. You didn't have to get a new DEA registration with your X number on it. You basically just could do this. And the caveat was you had to put an X on your prescription, and you had to indicate on your prescription that it was being written for opiate use disorder. So that was President Trump's plan. and it was supposed to become effective on the date that it was published in the Federal Register, but it was never published in the Federal Register. And I know the American College of Emergency Physicians are really excited about this, but again, it was never published because President Biden was elected, became president, and very commonly new administrations basically nix any unpublished regulations from the previous administration for 60 days, for the past 60 days. And they will also put a moratorium on enforcement unless they like the regulation, obviously. But President Biden did not think that the Trump plan was the best way to go. So it was on hold from January until April. And then in April, his HHS announced new practice guidelines to be effective on publication in the Register, which became effective the next day because it was published in the Federal Register the very next day. And his plan is that physicians, PAs, APRNs, as long as they're state licensed and registered with the DEA, if they want to treat just 30 patients, they can do that with the 30E level waiver, 30E level waiver. And what that is basically you don't have to take the course. Physicians don't have to take the 8-hour course. APRNs and PAs don't have to take the 24-hour course. When you pragmatically try to enter for this 30E level waiver, you go into the SAMHSA website, and where it asks you for the certification of your qualifying criteria, if you're a physician, you type in other. And if you're an APRN or PA, you select the PCSS box and type in other, and then, practice guidelines. Both of you, you would type in practice guidelines in the boxes that pop up. And then the date of whatever today's date that is when you are submitting. So you also don't have to do the attestation of providing or referring for counseling and ancillary services. But again, only 30 patients, and they have to be located in the state in which the prescriber is. So you can't have out-of-state patients come in to your clinic. And the time under the 30E does not count towards time that you can the following year upgrade to 100 and then subsequently 275. So say you did a 30E level waiver, you would have to get the training and attest to the ancillary services and counseling before, and get your regular 30 before you could qualify after a year to bump up to 100 patients. So in place of the 8-hour or 24-hour course, HHS developed a buprenorphine quick start guide for reference for these clinicians that elect to do to get this waiver this way. It's a little 6-page quick start guide, and Mithra, when she sends out these slides later, will also send the PDF of this 6-page little info guide, as well as the Federal Register where this new 30E waiver was published. So it just talks about buprenorphine and just the basics, how to assess, how to educate the patients, how to evaluate for withdrawal, make sure that you address co-occurring disorders, and then when on induction, talking about the CAL score and making sure that you don't induce precipitated withdrawal with induction, talks about the side effects, talks about diversion, and what to do with a patient if you do catch a patient that's diverting or misusing the medication. I found it interesting that, great actually, that the first line says just because a patient may misuse or divert doesn't mean automatic discharge from the practice. Sometimes that can be a sign of significant illness. And so looking at what their care plan should be, maybe prescribing less days in a row or putting in other safeguards. And then it has an algorithm for in-office induction that most people don't do anymore, but there is an algorithm for it for people that are interested. So why did these practice guidelines even change under Trump or Biden? Why did they do it? Because they think that these requirements, the training and certifying, is a perceived barrier. And I found that interesting. And I wanted to ask everybody else, for either yourself who became a prescriber or in your clinic when you've had a hard time getting maybe prescribers. I know a couple clinics that we've worked with the expansion grant have had some trouble. Was taking the course that much of a barrier for you or for people in your clinic?
And Tony, I always love to encourage everyone to either chat in or feel free to unmute and speak out.
Laura, are you able to talk? Because I know that there's been, you guys were looking for a prescriber for a while. Was taking the training, was that the barrier to having adequate prescribers?
That's not accurate for our experience, no. Taking the training did not seem to be an issue. It was more of the process that happened after that, of getting them submitting everything through, I believe it's SAMHSA, and then the Medicaid approval process. Yeah,
I mean, I think definitely our state, and the last slide will focus on that. There's a lot of requirements that at the state level. I personally didn't find taking the 24-hour course. We have to take it for continuing education anyway, some hours anyway, and I didn't find that as a barrier. So I just wondered if some people, maybe they are turned off, but what I hear most is the state kind of stuff, or just not wanting to work with the patient population.
And I see that Ryan typed in stigma, and I would definitely agree with that. I know we have approached some of our providers because obviously we want to have as many as possible in case somebody's out for illness or vacation. And some are just not interested because it involves addiction recovery.
Yeah, that's what I've heard from colleagues that are not, it's not because they have to take the course or even register with SAMHSA, it's that they just don't feel interested in the population. So stigma, yeah. So other pertinent waiver information, just little reminders. The waiver number is across practice locations. So if you work in one clinic or 5 clinics, if you have a 100-level waiver, you have 100 patients across all sites. There are also provisions for people that would need, for whatever reason, maybe a clinic closes in your area and you only, you have a 100-level waiver. You can request for an emergency 275 waiver. And, depending on the circumstances, SAMHSA will approve you for that, but it can only be for 6 months and you can have 1 renewal for that. And then there's also a provision while you're waiting for SAMHSA and the DEA to deliver your X waiver, you can submit a request to treat just 1 patient. 1 patient per form request. Say like you're a primary care clinic or something and you have a long time patient who needs treatment and can't find somewhere else. You've submitted for maybe this 30E exempt level waiver. You didn't take the course or anything, but they really need treatment now and you're really worried that they're at risk for harm. You can request from SAMHSA to get this provision to treat them before they've reviewed your application. The only hang up is then pharmacists might not, they can't look it up to see you're actually waived. However, there's a phone number that you can call or that the pharmacist can call to verify that you've been approved for this 1 patient while you're waiting for your application to be approved. And then unlike the OTP programs, which have an annual registration requirement, there's no renewals of waivers at the 30 or 100 level, unless you want to go from 30 to 100, then you do have to engage with SAMHSA with a new NOI. And then practitioners that are at 275 have to renew every 3 years, but they do have to file a report annually. And the other considerations, even if you do the waiver with SAMHSA, you get your new DEA registration with your X waiver number, you still have to adhere to state, local, and other policies. Our law is pretty arduous, although there is an attestation that's simplified if you just have 30 patients or less. much simpler than the whole thing with getting licensed from OFLAC to be an OB-MAT program. And then in West Virginia, Medicaid requires, in addition to the regular credentialing that you do, you have to send just a letter or an email to Medicaid to get on their list of prescribers to prescribe buprenorphine. Otherwise, your patients will go to the pharmacy and they won't pay for it. And then obviously there can be institutional policies. And those are the references.
Thank you so much, Tony. This was such an important didactic, and I feel like one that is really sometimes difficult to understand. So you did such a wonderful job just breaking that down and explaining it all. So thank you so much for your presentation today.
Thank you, Mithra.
Were there any questions or comments that anyone had for Tony? I know I'm sure there's so many questions that we could think of around this topic. So feel free to unmute and chime in.
Yeah, Tony, this is Fred Robinson. I got a question. You said it was not supposed to go over state line. I know a lot of times I deal with clients who are going to Pennsylvania, going to Ohio, or going to Baltimore to get, the buprenorphine. How is that done then?
If you have your regular waiver, like a 30 level, 100 level, or 275, that's fine. You can treat someone from another state. It's just if you have that 30E, that new one that came out in April.
Tony, that was wonderful. Quite frankly, to put it all in one place. Can't wait for the handout even. Is there have you seen, or anybody else really, any information on how many folks have taken our country up on this new version of things, especially given what our chat was on the stigma, not the CME?
I have not seen, that's part of the regulation, the new guidelines that they're going to track this. But I have not seen any data yet on it. And I would be surprised if I can see it being helpful if, the situation that I described, like someone's really, needing care in your primary care or other specialty location, not necessarily like psych or addiction, because you already probably have qualified prescribers there, but or maybe a clinic that something happened to their waived prescriber and you need a fill-in for a short period of time, but not someone that wants to do it, at least not now, ongoing. But I would really be surprised if this makes a world of difference. I mean, maybe it will, but I don't know that it's going to make a world of difference. I mean, I think what would make a world of difference is not having to have all the regulations to begin with, and maybe not having the limits, like the 275 limit, like someone that's been doing this for, a long time and they're certified in addiction medicine or addiction psychiatry, like why that 275 limit is there. I mean, I can theorize why they don't want someone to make that their sole moneymaker, because then they might be enticed to, redo the opioid epidemic of overprescribing. But with the number of people that lack interest in this area, I think that's probably going to be the only way, at least right now, that you could get adequate supply and demand matching. But I'll let you know, Mark, if I see data about that, see how many people.
I can chime in to somewhat answer your question, Mark. Here at Cabot, we have 20 different prescribers. About 5 or 6 are ex-waivered, and the new rule caused our one person to do the NOI, and they were able to fill in for me, and it was a big help. But no one has wanted to actually do it within their normal practice, the way that they had conceptualized that primary care doctors would just sort of, up to 30 have keep them under the primary care roof. And part of the reason is actually the way that we're paid. You get paid, at least for fairly qualified health centers, per visit. So you don't want to address 50 different complex problems per visit. You want to separate it out. So it's not even a stigma issue. A lot of our providers would see these patients and keep them in their primary care clinic if they could get a separate visit and get them there instead of having to handle that plus 5 other problems in a single day. So it really has to do with bundled payment that causes this primary cares don't want to do it, not just stigma. I just wanted to clarify that.
Thank you all. Oh, Dr. Houston?
Oh, I was just, yeah, sorry I was late, Tony. Good job. The thing with Medicaid, the authorization, that is a huge problem. As a fellow, it took me like 6 months for them to approve it for Medicaid, which is insanity. That you send them an email, which should be just basically, you know, dotting an I, crossing a T, and it became a huge thing that really interfered with being able to prescribe medicine. So I don't know if anybody else has had that problem before, but I mean, I just wonder how many people that actually got this expansion thing, and then they're still waiting on the state to actually do their job. So.
Laura, I saw you nodding in agreement. Did you want to comment on that?
That's exactly what I was talking about that we experienced with getting people approved to be prescribers. Like I think I had one provider that completed her training, and it took, I think, a total of like 13 months before everything was approved and she was good to go. So it was a very challenging process. Of course, I was brand new too, so I mean that didn't help, but I'm a lot better at it now.
It doesn't seem like it should take that long, because I can't imagine there's maybe more than 1 or 2 people a day that are requesting. I mean, this is probably something that I don't know, on a state level somebody should address, because this shouldn't take more than a week. And
I know with my specific situation too, this was a nurse practitioner, and the hours that she completed for the program, for the waiver program, first had to be registered and acknowledged through the Nurse Practitioners Association. And for like, I don't know, it felt like 2 months, I would call daily and get the recording that they were all working from home and leave a message, and nobody would call back. It was very frustrating. Of course, that was also right in the midst of when we were all new to the COVID chaos. But I do have a question, and it's kind of off topic a little bit. If it's too much off topic, definitely we can park that and look at it later. But recently came to my attention that the visits for our MAT patients have to be prior auth on a weekly basis through Medicaid. This has been put in on my desk to take care of. And so I'm just wondering if anybody on here has any experience with that and knows what that entails.
So are you talking, is it through the Molina system, through direct Medicaid billing?
I guess I am not a billing person, so
what is your organization? What?
Minnie Hamilton Health System, or FQHC.
Okay, so you'll need to contact Medicaid and get a Molina login and user name and password, and be assigned a case manager, and you'll have access to their system. And you'll have to fill out all the pre-auth information and request those authorizations. They're pretty quick turnaround. Authorization usually comes in 1 or 2 days, but it's 3 screens that you'll have to fill out with the patient information. And then the last screen is the authorization page with the list of the authorization numbers. Group, it'll be a 90853. For therapy numbers, it's a 90832. For 30 minutes, a 90934 for 45 minutes. A 90837 for 60 minutes. And if it's straight Medicaid, you can bill an initial intake. Sorry, y'all laughing at my mommy. It is a 90791 for initial intake, and you can bill for that initial assessment.
Awesome.
If you need any help, I'm more than happy to help you, and I can get you a link to those numbers if you need them.
Beautiful. Thank you so much.
Is that new, or is that? something you guys have already, I mean, I don't do, and you have to do it every week or
See, I don't know. I mean, I think therapists, those are for therapist authorizations and not so much for medical. And no, it is not new. Where Medicaid is broken out with the underwriters or the other payees, the third parties, like Aetna, for
the health plan and
the health plan. Yes, thank you. Yes, but if they have straight Medicaid, then you have to do these prior auths. So it's always been there. FQHCs has always had to do it. She's just probably new at I don't know. There might be more coming down your pike that are straight Medicaid. I don't know. But if you need any help, I'll be more than happy to help you.
Thank you. Yeah, I think this was something our agency's billing department was initially doing, but they're not doing that. Well, for therapists, billing departments cannot complete those screens because it's specific information per patient. It's based on, the diagnosis, general history, like levels of care and treatment, and medical necessity has to be completed on those screens in order to reach that, to have those prior authorizations. Okay.
Whenever you are assigned a case manager, she will help you review and how to navigate that system.
When I'm assigned a case manager with Melina?
Yes.
Okay, gotcha.
Yes.
Thank you.
And Nancy, I think, did you have a comment you also wanted to make? I noticed you unmuted there.
Yeah, I am. I'm not muted now, am I? Can you hear me? Okay,
yes,
good.
we can.
Okay, it relates to billing also. What we're running into at CAMC is that they are cutting us off at 12 visits per Medicare. So of course our patients, cannot self-pay. So I've never run into this because, dealing with this population of people is quite different than what I was doing solely in the past. Anybody run into that or have any kind of advice on how we can tackle it?
Did you say Medicaid or Medicare?
Medicare. Solely Medicare recipients, yes. And of course, they're the older population and they can't pay out of pocket. And secondary, and this was my question, Heather, into the group, primary and secondary, well, if Medicare is their primary, their secondary won't pick it up.
No, they will not. Absolutely, they will not. So with them, again, you need to contact them and tell them what you're treating. You'll have to do a treatment plan. You'll have to send them a documentation of their treatment and the modality of the treatment with a plan, and then most often give you more units, but you'll have to do that probably every 3 months or so.
Well, what I'm running into is from somebody who was a biller in the private sector, and they had said that if we advocate for the patient, then it prevents them from advocating with Medicare for themselves in the future. Have you ever heard of that?
No.
Okay.
No, I don't know what they're referring to.
Okay.
Also, you cannot bill. You might need to check into this, but if it's you cannot bill a medical visit and a therapy visit on the same day.
We're aware of that.
Okay.
Yeah. Okay.
They will not accept those.
I appreciate it. That's very, very helpful. So treatment plan, documentation, and modality with the plan included.
Yes.
Okay, like evidence-based practice or.
Yeah. Yes.
Okay.
And they should, I think there's a form that you can go online and find, you just call them and they'll help you. You may have to go through several people, but eventually you'll get the help you need.
Appreciate it. Thank you very much.
Thank you so much, Heather. That was awesome.
Well, I've been in FQHCs and I've been in behavioral health, so I've seen all of it, and it's fun times dealing with insurance.
Oh, I can imagine. I did want to read out this chat from Marianne a few minutes ago saying she completely agrees with Ryan. If you're working as a primary care physician, it's impossible to adequately address a patient's substance use disorder in a 15-minute visit dealing with multiple other medical issues. Marianne, I didn't know if you wanted to expand on that a little more, but thank you for chatting that in.
Sure. I am a former family medicine physician, so I guess I have an idea of how difficult it is to be trying to manage diabetes, COPD, heart disease, and substance use disorder all in one visit. So I definitely see why there'd be hesitancy among primary care physicians who are practicing pure primary care to want to get involved in addiction care, unfortunately.
Thank you so much. Were there any other comments or questions from the group? Dr. Morrison, I just wanted to say that skeleton Grim Reaper looking thing in the background really scared me for a second. So I think it's doing a good job. All right, any other last minute comments? I would hate to end it short. Mark, thank you for chatting that in. Oh, TED Talk, that's awesome. I can include that in the recap for sure. Thank you for sharing that. Do you want to?
Technically TEDx, but you know.
That's still awesome. Thank you.
Guys.
I'll add it in the recap email. We'll check that out. Anything else? All right, well, you all are so awesome. Thank you so much as always. And thank you, Tony, for the great didactic. I'll be sure to include all the attachments in the recap email so you all will have that information in there. My only announcement is that our next session's on October 11th, and Dr. Husted will be discussing long-acting buprenorphine. And in honor of Dr. Husted presenting, I'm trying to rally everyone to either wear buffalo plaid or floral, because we know he's all about that. The only kind of plaid I have is a green one, so I